For our last presentation before we have the question and answer panel is, it'll come from Jeffrey GOAD, who is the tenured professor of pharmacy practice and the inaugural chair of the Chapman University School of Pharmacy. Jeff, if you'd like to start. Thank you.
Yes, thank you. Can you hear me okay?
Yes, and I can see your slides.
Okay, perfect. I love going last, so I'll try to catch up some time here so we have some time for questions and answers. As pointed out, this is looking at the role of pharmacy in community-based interventions for increasing vaccination rates through access and a number of other means. So just to start off with, I think it's important to kind of look across, and you might have seen pharmacists giving vaccines in different settings. But I do want to mention that I think this approach that I'm going to describe as a case for pharmacy-based immunization is applicable to many different places around the world. It really just takes access, expertise, and operational efficiency to be able to deliver vaccines in a community as part of the immunization neighborhood. So you see a lot of different settings. That's me down there on the right, excited to get my shot in my pre-pandemic haircut. So let's go ahead and we'll start off next here. Okay. Now, first, just to level set everyone. Again, this is a US based presentation, but I think there's a lot of takeaways for other parts of the world. In the United States, we really started in a big way of pharmacy getting involved in vaccinations about 1993, when the Health and Human Services Office asked us to really define the role of the pharmacist in providing vaccines. What is it that we can contribute? And at this time was to adult vaccination. And then shortly after that, we actually developed a national immunization training program through the American Pharmacists Association, which if you look at the graph on the right here, that blue line, that's the number of pharmacists that have been trained since about the early 2000s when we started documenting the number of trained pharmacists. And we're well over 320,000 people, or pharmacists rather, trained on this CDC recognized National Immunization Training Program. Now, go over to the access side and states and territories and what pharmacists are allowed to do. In about 2009 is when we finally hit the breaking point where all states allowed pharmacists to administer influenza vaccine. And you might note the date, that's also the pandemic, right? So that is our flu pandemic of 2009 that really spurred on a lot of collaboration and partnerships with community-based pharmacy. So you can see the green line there are the number of states and territories that came online, in other words, to allow pharmacists to administer influenza vaccine. And as we hit 2009 and on past that, we now have all states allowing pharmacists to administer influenza. But in addition to that, we also have all states in various forms, either by prescription or protocol or independent authority, to give meningococcal vaccine, TD and Tdap, zoster, and pneumococcal vaccine. And in fact, 47 states now allow the pharmacist to administer any vaccine. Now, when we talk about pharmacists and vaccination, we think about it in terms of a neighborhood of other providers. So I think it's important when we talk about providers providing vaccines that they walk the walk and talk the talk. So for pharmacists, you can see here in the red line, I tried to highlight here, although we really started documenting pharmacist vaccinations about 2012, since then we've been pretty steady at between 85 and sometimes over 90%. But I think the real story too is that nurses and physicians and everyone now is at the 90% plus, which means if vaccinations are important enough for our patients, they're also important for the provider. Now, over to the side of access and what pharmacists have done in terms of immunization rates. So on the left here is a chart looking at from the late 90s until current time, the percentage of vaccination that's estimated to have been administered in community pharmacies for influenza vaccine. So as you can see here, it's gone up over the years to where we are right now, which is somewhere around 32%, looking at the 2018-2019 influenza season. And if you contrast that to other providers, you can see that pharmacy has quickly emerged as the second largest provider of influenza vaccine in the country, only followed by physicians' offices, or sometimes we call traditional vaccine distribution areas. And for pediatrics, however, it's a smaller percentage. Again, we were asked in the early 90s to join the adult vaccination campaign, where LJ pointed out we still continue to struggle to get immunization rates up. So this is at 32% is something that we'd like to see go higher. Now, one of the other things that we think about is, are we just shifting populations from the physician's office to the pharmacy? And there have been a lot of studies to show that actually we're expanding access, we're expanding the vaccinated pool, so not just shifting. Now, I do want to highlight that there are some areas where we could do better. So in influenza, although we're increasing in the amount of vaccine we're given, we do still have a problem with certain vaccines. So for example, while flu and Tdap can be given universally by pharmacists in all states, for pregnant patients, there is a drop-off. So for flu, for example, we only represent 10% of the vaccines that are given. And for Tdap in pregnant women, we're only around 7%. So there's a bit of a perception issue. It's really not a legal issue. So in other words, pharmacists are trained, they can give it, but it's a bit of a perception issue on patients that they can come to the pharmacy, not just for flu and not just for non-pregnant patients. So a bit of education that we've been working on to help increase immunization rates. Now, I think one of the other areas, and this is one I started out with, saying that access is a major issue with expanding pharmacy-based immunization. Now, this is a study that I did with a large chain pharmacy to look at about 6 million doses of vaccine administered over one season. And what we're really trying to do is look at a model of clinic-based, so in other words, 9 to 6, Monday through Friday, typical hours, versus what pharmacy can offer in extended hours, right? So before 9 a.m., after 6 p.m., which we call sort of off clinic or after hours. Now, what we found was what we expected, which is most people will come in between 9 to 6 to get vaccine. That's about 70% of the population we looked at. What was interesting though is about 30% of the population, so the other part of it, came in at other times. Now, influenza was still the #1 vaccine that they came in for at about 85%. But we also saw a scattering of other vaccines, about 15%, were everything from routine other vaccines to travel vaccines. And 10% were given in the evening. One of the interesting takeaways is that somewhere around 182,000 people got a vaccine on a federal holiday. So people take holidays as opportunities to get shots as well. In the demographics, what we expected, of course, about nearly half of the people getting a vaccine in the pharmacy were 65 or older, and only about 3% were less than 18. Again, that's to be expected. Which was a little unexpected, however, is when we looked at the after hours side of it. So again, before 9 a.m., after 6 p.m., and now the ratio inverted, so that we had 22% only of those over 65 coming in after hours, but 51%, and keep in mind, it's a small percentage of 3% of the total population, but 51% of those less than 18 came in to get vaccines. So this may represent parents who need to come in after work to get their teenagers vaccinated. So there was a lot of opportunity built into expanded access. Now, I do want to point out that when I mentioned before that all 50 states allow pharmacists to give vaccines, it's with an asterisk next to it, meaning that there are differences from state to state in how pharmacists can administer vaccines. So one of the ways that we've been promoting throughout the US to get pharmacists and the lawmakers that govern the practice of pharmacy is to create what's called state authorized providers. So for example, in 18 states, pharmacists don't need to get a prescription, they don't need to have a protocol with a physician, they are independently authorized to administer vaccines. And in this case, influenza in 18 states. But I do want to point out, and this is where it's important as you begin to think about scalability and expanding out, is that there are age breaks. So, you know, everyone from 3 years and up, which is where I am in California, was chosen as the CDC break between anatomic locations of vaccinations for kids. From the, you know, from the vastus lateralis to the deltoid, CDC puts it at 3 years. So we chose that. But there are a lot of other age breaks that need to be taken into account. Now, the case then for pharmacy-based immunization. In the US, there are about 88,000 pharmacies, community pharmacies, about a 50-50 between chain, which are the large corporation-based pharmacies, to independent pharmacies, and that varies regionally, that proportion. There are well over 300,000 licensed pharmacists, and about 50% of them work in community pharmacy. Pharmacy is actually the third largest profession in the country behind physicians and nurses. And about 86% of the US population live within 5 miles of pharmacy. In fact, if you look at this map over here on the right, this is a density plot of pharmacies per 10,000 people. And you can kind of roughly see throughout the nation where we have a density of pharmacies and people represented. In the West Coast, it does look less, but keep in mind, we tend to have larger urban metropolitan centers like Los Angeles, for example, where I live. So access issues, all 50 states allow pharmacists to give vaccines. Pharmacies have extended off-clinic hours, which are going to be important when you're extending the vaccination period. Training-wise, again, that expertise area. In fact, pharmacy schools of pharmacy are required to teach immunization as part of their curriculum. And of course, we do have a national CDC recognized training program that all pharmacists and pharmacy students go through. So just some final thoughts here on when we think about a pandemic potential, right? So this is looking at a Monte Carlo simulation for a simulated influenza pandemic, just to give you an idea of when you combine different modes of delivery together. So for example, multiple providers reduce the stress on any given system. If you look at the right over here, if only clinics were giving a pandemic vaccine, for example, they would have to carry the brunt and they couldn't give as many vaccines. That means routine care is going to go to the wayside as you try to administer a pandemic vaccine. One of the other messages that came out of this is that you need to start early. We didn't get the chance to do that. I think it was pointed out by Saad early on. If we'd had a vaccine ready in March 1, we would have been able to maximize this model. And also thinking about maximizing the operational efficiency to give more immunization. That's highlighted here in red, which is if you give traditional, which are clinics, plus pharmacies, all locations, and make that efficiency of vaccination so that the throughput is higher, you can see that we can give more vaccine and it distributes the load out so that we can avoid, in this model, upwards of 23 million symptomatic cases of flu, saving $2 billion to insurers and the societal impact near 100 billion. One of the takeaways, history is important if we don't learn anything. From 2009 H1N1, pharmacy was invited to participate late in the game. So they started distributing in about December. Over December to February, CDC distributed 5 million doses of the pandemic influenza vaccine to pharmacy chains. And overall, pharmacy administered 10% of every dose for pandemic vaccine in the United States. Could have been more if they'd started earlier. So we need to learn from the lessons and use all of our partners to make sure we have an efficient, effective, and safe vaccine delivery system this year. And that's it for me.